Thank you, Greg. It's my great pleasure to be here. And it's nice to see that the hair session is fully crowded, so that's excellent for you. Thank you. I don't know if you ever faced closely a red kite. This is called Milvus milvus. If you haven't, just try go bird watching. It's one of my favorite things during the weekend. You might enjoy doing that. But it's not about birds I'm going to talk today, but it's about if oral minoxidil is better than topical. And do we really can answer that question? How do we measure results in hair conditions? Do we have any scientific method that can be reproduced and it really works in all patients? I'd like to focus on that on my talk. In the last meeting in Barcelona in 2019, we started with a group of researchers from all the world trying to find consensus on some of the diseases we were dealing, on some of the treatments we were dealing, and we published a couple of papers regarding that, and there are a lot of controversies in trichologies, and if we try to get consensus, it's not so easy at all. And you can have a look in here how many discrepancies we have in such things that everyone would believe they are true. So let's start just critically reviewing some of the literature. This is from our friends in Madrid. This is a nice paper on reviewing the group of Sergio Vagnot, the effectiveness and safety of low-dose oral minoxidil in male androgenetic alopecia. This was published in the Blue Journal, so it should be well reviewed. This is another article from Antonella Toste. She's one of the big bosses in hair research in the world, and she was also reviewing some of the papers that are here and there. In this article, the group of Toste studies different studies. She's not performing the study herself, just reviewed 17 different studies, and they try to see what's the differences on those studies, and they found that oral minoxidil was found to be an effective and well-tolerated treatment. But what does effective mean? How do you state if a treatment is really working or not? Do we believe on the amount of hair shedding? Do we believe on trichoscan methods? Do we believe on mass system of counting here? Are the clinical images enough for telling if something is working or not? Well, the treatment was well tolerated, and you can be sure of that, and you can measure how was the blood pressure. So it's not decreasing blood pressure. There are other articles on the same, and this one, it's a big one, and you can have a look on that one. The low-dose oral minoxidil as treatment for non-scarring alopecia, systematic review. They also reviewed 1,900 patients treated in different studies. They were not treating them. It's the same as happening with PRP. Most of the articles are not performing themselves the research, but they are reviewing research from others. And the conclusion on that article is that oral minoxidil is a safe and successful treatment for androgenetic and alopecia areata. Do you believe that minoxidil works on alopecia areata? Have you ever tried on a total alopecia areata to apply minoxidil? Have you seen any results? I don't believe alopecia areata responds to oral or topical minoxidil. But alopecia areata has a kind of a crazy pattern responding mostly on patchy alopecia areata. So you might have responses but not related to your treatment, but related to the evolution of the disease. So if you put in the same bag androgenetic and alopecia areata, I don't believe this type of papers you have in here. There are other results from the group of Australia, excellent researchers, very good, well-known researchers from the world. We are good friends with Rod Sinclair, and they do here a review on the treatment of male pattern hair loss. Also, the group of Bianca Maria Piraccini in Italy, they work very well, and we are good friends, and we see each other in many meetings, but they tend to do the same type of a problem. This is a paper I really like. and they don't try to see how effective it is. They don't try to discriminate if it's better to use topical or oral by the results of it, which we cannot answer yet. But they try to see from a patient point of view, which in fact it's quite important. So they were treating just not a lot of patients, just 18 patients, and 5 of them reported. The patients reported increased scalp hair. So they had the feeling that the treatment was working. And some of them, 40%, reported hypertrichosis, mostly on the face. Blood pressure was normal. Why is this article interesting? Well, because it deals with patient satisfaction. It's convenient. It has a better cosmetics. You don't have to be all your scalp just stinky all day and the pillow getting yellow at the end of the month. It costs less money. It can be used as a co-therapy if you want to use hair fibers or your hairstyle don't want to be disturbed. Many ladies just go once a week to the hairdresser, so they don't like to apply topical minoxidil. And it has a better compliance. Patients prefer to take a pill than to apply something which is dirty and non-pleasant. In the two days ago, in the American Academy of Dermatology in Boston, there was a state from Antonella Tosti saying, consider prescribing low-dose oral minoxidil in all hair diseases. And Antonella does not have a conflict of interest with minoxidil, as minoxidil cannot be bought by a single company. But do you really believe we have to add oral minoxidil to all type of diseases? Is it really worth? Has it really any sense on the pathogenesis of any hair problem? Sometimes we read articles that we don't believe, at least it happens to me. I have a critical view on articles. I see some articles from a strange herb somewhere in the south of India, and they found excellent results just taking those pills of something in Kobilov, I think. I think it cannot be true. I doubt it. And later some other authors, if they perform well-performed articles, they deny the results. How's that? Why so many clinical trials are not showing reality? What's happening with hair? Why can I buy a slow laser device and show good results? And then if I try to apply it to an evolved Ludwig VI man, I have no results at all. Is it really working? How can these results be not showing reality? Well, I think that many patients tend to be happy with new options and mostly feel good when you are involved in a tight follow-up. So if you try to perform a study on a patient, they tend to be happy with the study, so they tend to see the bottle half full. Many patients also believe that the hair shedding, hair fall, is the real cause of their problem. But hair shedding keeps changing on the months. We are still mammals, and we still have this transient, monthly changing shedding. So if you start a patient in a shedding period, in 3 months he'll be happier, always, and they will believe it's related to the treatment you are giving to them. Hair shedding is influenced by weather in mammals, and we are quite of animals in believing this type of problems we're facing, so we tend to get in a non-malting period after starting a treatment. The Canfield orthostatic device is not showing as much reality as we would like to, because patients do not have exactly the same length. The amount of humidity in the air is not the same. They don't have the same style, even if we ask them to come with the same idea. So I've performed many clinical trials with these Canfield systems on getting pictures of patients, and we cannot get enough good results to tell if something is working or not. Pull test. You know that pull tests change a lot during the month, so you cannot rely the results of a treatment just by pulling your patient's hair. trichogram can be quite useful examining the roots of your patients, but if you want to do it properly, you need to pull 100 here, and most of your patients will not be happy if you try to do that to them. So if we don't want to perform old-style trichograms, we have new phototrichogram. Is it really working, phototrichogram? We have seen from Dr. Ratchataporn from Thailand that they do it very seriously. I also do it very seriously, and I invite you to try to do something which is very easy. Just call your first patient and perform a phototrichogram with a tattoo. Then put him back to the waiting room, and in half an hour do it again. And see that the numbers will change, even if we try to do it very strictly with a tattoo. And I've performed many half a scalp studies. We don't find the same results because it's not so easy to count exactly the same number of hairs. So in conclusion, we cannot really answer if something is working or not. Doctors like new options, so we are bored of using topical minoxidil. So most of us are happier to have something new, and patients tend to like comfortable treatments. Indeed, so if you feel like adding oral to all your patients, just do it. That will harm no of them. And I'll invite you all to come and join us in Barcelona in September next year, barcelonahair.org, and we will be discussing about evidence and non-marketing issues on hair problems. Thank you very much for your time.